so this is what we're going to talk about today. I realized from the chat that we are not the only ones who are doing this. So we're going to talk about how and why we have been training certified peer support specialists to serve as community-based doulas to support our families with perinatal substance use disorders here in South Carolina. And we're going to share what we did and how and what we learned from it. And again, we would love to hear from you all around the country, similar projects that you've done, similar lessons that you've learned, or other things. And I will introduce everybody and then get out the way. This is the folks that have been involved in this project. We have Courtney King, Dr. Courtney King, I should say, who's Associate Director of the Women's Reproductive Behavioral Health Division at Medical University of South Carolina down in Charleston, and her Certified Peer Support Specialist and Community-Based Doula, Janessa Cochran. And from Birth Matters, Molly Chappell-McPhail, who's the Director of Advocacy and Expansion, and if I may, the founder of the program, and a wonderful hero and partner around the state. And then you have me down at the bottom. I work for the Center for Community Health Alignment at the Arnold School of Public Health at University of South Carolina. Just getting my modus operandi is to support community health workers, community-based doulas, and certified peer support specialists in any way they will let me. So I'm going to pass it over to Courtney.
Thank you. So I'm going to try not to spend too much time on the background. This is the stuff that I really love to talk about. So you guys can tell me to move it along if I get too stuck in the stats. But South Carolina, our state, is maternal mortality rate is the nation's 8th highest. It's coming in around 25.5 per 100,000 live births. And our South Carolina Maternal Mortality Review Committee has determined that mental health conditions, which include substance use disorders, depression, suicide, are one of the leading causes of all pregnancy-related deaths. So you can see over on the side the contributing factors to pregnancy-related deaths. Substance use disorders specifically contribute to almost a third of all pregnancy-related deaths that were reviewed, with drug overdose, primarily due to opioids, being one of those leading causes contributing. Can I change the slides, or Sarah, are you doing it? Okay, got it. Thank you. So unfortunately, opioid overdose rates in South Carolina are also some of the highest in the country. From 2019 to 2020, an example is that South Carolina experienced 60% increase in opioid overdose deaths, and an even higher increase in synthetic opioid-related deaths, so fentanyl being mixed in with other drugs. And opioid use among pregnant and postpartum people in South Carolina mirrors these trends that were observed in the general population. So an example of this is in 2020, so mirroring that period where we saw that huge increase, 882 pregnant women in South Carolina were admitted to treatment for substance use disorder. So those are just the women that were identified. And in a 4-year period from 2016 to 2020, the incidences of a neonatal abstinence syndrome or neonatal opioid withdrawal syndrome now is increased by 25%. And so I know I just gave you a bunch of discouraging news. I always start presentations that way. But the good news is, if you go to the next slide, please. The maternal mortality review committees from 14 states, including South Carolina, determined, I think, February of last year, that 100% of maternal mental health related deaths are preventable by 2 relatively easy things. 1, improving screening, identification, and identification of perinatal mental health and substance use disorders. And 2, ensuring access to comprehensive evidence-based treatment and recovery services. So that includes things like care coordination, medication for opioid use disorder, and wraparound services that really address the psychosocial needs of women and the mother-infant dyad. So despite these recommendations, only about 25% of women with perinatal opioid use disorder specifically receive treatment. So that is 25%, if we think about that 800, almost 900 number, there's another 3/4 that are not receiving treatment. And among women who initiate medication for opioid use disorder, which is our gold standard treatment that we know is successful, 56% will discontinue their medication by 6 months postpartum, which is really significantly increasing their risk for relapse, overdose, and death. So we're seeing these really high numbers of pregnancy-related deaths. Next slide, please. And so some of the reasons that we know that women are either not getting treatment or discontinuing treatment is that pregnant and parenting people with opioid use disorder are a highly, highly stigmatized population, even within medicine, but also within the recovery community itself. And as a result, they often avoid healthcare, they avoid prenatal care, recovery support services, due to a fear of social and legal consequences that often are it makes sense that they feel that way. They're not unfounded. And even if they're receiving appropriate prenatal care or appropriate postpartum care, there's a perception of blame, maternal shame, again, that fear of punitive response by providers that a lot of times impedes mothers' disclosure of their opioid use, whether they stopped during pregnancy and has started up as a new user or has relapsed, or their opioid use disorder in general. And it really deters them from these life-saving treatments for perinatal opioid use disorder that we know improve maternal, fetal, and newborn health. And in addition to the psychosocial issues, this population often faces challenges accessing healthcare, especially in the state of South Carolina, that's highly rural, highly medically underserved. There's also barriers including like a lack of transportation, lack of childcare or time off from work, paid time off from work required to access services, as well as a lack of availability of services in their area. Sometimes these medications for opioid use disorders, depending on the one they choose, can be very time consuming and difficult to get. So we know through our team's efforts to understand and support this population, as well as a growing body of research in this area, that emotional, tangible, and affectionate support can really improve attendance and engagement in treatment for perinatal opioid use disorder. So specifically through a lot of the qualitative work that I and our team have done, that's aimed at better understanding where care is falling short and how we can support these mothers and their families. We have consistently heard that these women really just want to be heard, seen, and understood, and especially want to talk to other individuals who have been there. So sometimes there's I'm interested in peer support services, but what I really want to talk to is another mother in recovery. We hear that all the time. So next slide, please. So this model of guiding and supporting through lived experience and shared understanding is longstanding in the substance use disorder community and the recovery community, with peer support specialists, certified peer support specialists, or recovery coaches. They're called different things in different states. And a certified peer support specialist is an individual who brings the lived experience of successful recovery combined with training and supervision to assist others in becoming and staying engaged in the recovery process. So again, through that shared understanding. And this is a model that has been around for a really long time in the recovery community. It started, it's really common as sponsors in AA and NA. What makes them a certified peer is just the continued training so that they can kind of move between and integrate into medical treatment services. So for our specific population, we required 1 year of sustained recovery, 46 hours of credential training from the addiction professionals of South Carolina. So that's our certifying body within South Carolina, as well as lived experience of perinatal substance use disorder or recovery in pregnancy and postpartum. So they bring that really shared experience of what was happening during the perinatal period, with the idea that this might help break down some of the barriers of experience and understanding that people are facing within healthcare, and can be a bridge between some of the power dynamics that get in the way of working with members of the treatment team that might not understand what these individuals are bringing into their pregnancy. And so I will hand it over to Janessa, who is one of these peer support specialists that is serving a perinatal population, and let her talk about her experience and what she does on a daily basis.
Thank you, Courtney. So as she mentioned, I am a certified peer support specialist. I'm a person in long-term recovery and a mom of 5. And when I was approached with the opportunity for this training, I really thought to myself, wow, I wish I had had someone like this to walk with me. And so I, just jumped in. And I just wanted to discuss, just a few basics of what a certified peer support specialist does. And let's see.
Do you want me to put the slides back up, Janessa?
Yeah, please.
Okay.
Thank you. Would you mind hopping to the next one first and then backtracking? Thank you. There we go. So first, I just wanted to discuss the recovery and wellness. Really, the main focus is just, we're walking alongside the individuals. We are showing them all of their options and allowing them to choose the best thing that fits them, whatever option is going to be best for their needs and their desires. We're a non-judgmental safe space, just kind of serving as a mentor, somebody that's been there, somebody that, has already dealt with these things, and someone that can help them kind of break down those barriers and help support them and advocate and empower them to, to walk through it as well. And we're really just providing a lot of education and informational support. I'm sorry, lost my spot. The different pathways to recovery, and helping them build recovery capital, which is really just the things that make recovery work. So like housing, transportation, if they just need support with work, stable income, all of those things that really help someone function in the day-to-day and support their recovery. So we use MI, which is motivational interviewing, and shared decision-making techniques, just to really help them build on their strengths and focus on what they're good at and work from that. Because a lot of times, we feel shame and a lot of just regret and things about our past, and we don't really know what we're good at or where to begin. So using those techniques is really a good way to help people identify the things that they are good at and their strengths, and to help them, focus on that and move forward. We're really just empowering clients to advocate for themselves while respecting their, their cultural differences, personal choice. There's no one pathway to recovery. So everyone, is open to whatever their choice is. And we support that, and we're going to help them walk through that. And we really want to recognize indicators and, risks, and just figuring out how to de-escalate those things and to help support them. And let's see, staying up to date with, oh, sorry, Sarah, if you want to back up one, yeah, there we go. So if you, staying up to date on the latest trends and, doing trainings, education, constantly, everything's changing, right? So we're constantly developing more skills and learning how to better help support the people that we're working with. And we are, sorry, lost my spot again. We're respecting the cultural differences, recognizing and responding to personal risks, maintaining current knowledge of trends, and helping people to really move forward and address some of the stigma, the boundaries, the issues that they're facing. Sorry guys, my screen went blank. I lost lost my notes. But yeah, we're really just a non-judgmental safe space. We are walking hand in hand with people. We are, we're not above them, we're beside them. They're our peers, just like our title says. So we're really just helping folks to figure this out because we've been there and done it. And, it really does prove to be helpful. People are more open, more willing to engage, they're more honest, and they're more willing to listen to someone that's been there and walked through it already. So those are just a few of the basics. And of course, there's a lot more that goes into that. But when I did this training, I recognized the similarities in the peer support model and the community doula model and how well that they coincide. And so I'm going to let Molly discuss that more, but it's really proven to be, I think, a really interesting model of care for people, especially for moms in recovery.
Yes, thank you so much, Janessa. So yes, a little bit about the community doula world in South Carolina. So Birth Matters is the organization. We are a nonprofit, and we have existed in Spartanburg, which was one county in South Carolina, for 14 years. And a couple of years ago, we really started seeing other states advance community doula work and thinking about reimbursement models. And so Birth Matters, our leadership team decided we wanted to take a lead and take a little leap of going outside of just one county. And how can we support our full state in understanding the differences between community doulas and how the lived experience is the magic sauce to being community doulas. I do not identify as a community doula. I train and support others to become community doulas. And in Spartanburg, we're an accredited Health Connect 1 site. So that means that we have been accredited by a community doula organization that deems us using their essential components. And one of the big pieces that are different with our model is that we believe paying people salaries and benefits to practice in this role, because it's really hard to be doulas right now. It's really deep work. You can hear from Janessa, she's every day, she's personally waking up and make sure she's staying in her recovery, and to be working side by side with someone else, and not just one person. Your caseload she's early in it, but her caseload could get up to 18 to 20. And, really supporting on a weekly basis that many birthing persons, whether they're in the pregnancy or past, it's a lot to take on. And so our model believes in nurturing doulas and really supporting them to ensure they don't burn out and leave the field. So our training is the first step. We love our training. We believe in our training. It's not a weekend gig. It's a long, it's 3 months commitment, and we digest things weekly, and we help process the critical thinking information. And we do a lot around ensuring the absorption. So you just heard a lot of the competencies with peer support specialist. We're very similar in the fact that we want to ensure understanding, and ours is a little different because we are all around the birth. This one big transition time in a birthing person's life. And so we add the layer of understanding everything there is needed to understand about birth. The important thing is that, we do know that community doulas are part of the solution. We're not here to say we're the only solution. We are non-clinical, so you've heard that, but I just want to validate that because I know some people possibly don't know what doulas are, and we are not midwives. There's been confusion and there will continue to be confusion. Midwives provide all the clinical. They just have a very strong emotional support component to their model. Doulas do the emotional support. We do all the information and education. And as Janessa really nicely emphasized, we are all about informed decision and shared decision. So we are not an expert. We do maybe know a little bit more than someone who's never had a baby before. Our knowledge might be a little higher when it comes to understanding birth and things like that, but we do not want to be perceived as that. So, we do a lot of role playing around, well, what did you do for your recovery? Or how did you birth? What did you do? You have to forever make sure you say, I can share my experience, but my experience does not mean that's what your experience needs to be. So always helping every individual know. And if you've been a part of, you saw what Dr. King talked about, all the stigma and a lot of the bias that is, unfortunately a part of a lot of systems that persons in recovery encounter. Being oppressed and being in a place where you don't even know how to make a decision and all you want is someone to make decisions for you, we go alongside when someone is in that trauma response. We can identify it, we understand it's happening, and what we want to do is breathe with them, share the space, help them improve some coping mechanisms, and help them make an empowered decision that's right for them. You can go to the next slide. This is specific to some of the things I was just mentioning, which is, we got excited when MUSC presented this idea to us, because again, we were early in the outside of serving women of color in Spartanburg County. That's been our niche. That's been, Medicaid eligible families that were younger in age. That's what we knew in Spartanburg. So when we stepped out of Spartanburg and started thinking about statewide partnerships and collaborations, we got really excited when we saw how MUSC was looking at this and thinking about the lived experience for persons in recovery. And of course, there's evidence. You heard that. You heard the why we're in this place right now in South Carolina. And so it was a beautiful concept that we, of course, didn't take long to say, yeah, this totally would make sense. So we got excited and we definitely wanted to offer this. We did a lot of content because MUSC selected 5 different people. You saw them in the previous photo, and they were from 4 different communities. So we had to adapt how we were going to use our curriculum and how we were going to help it work for all the communities. And so it was, we were on the end of COVID. So Zoom did help us out to provide the content of the information. And then we had lots of Saturdays together, long Saturdays, doing the skill building and the role plays and reflecting on the content. We did add, so Health Connect One's curriculum is very specific to general concepts with pregnancy and birth and postpartum. And we wanted to add this special layer for recovery and understanding best practices, how you could explain some of these concepts to someone in a same language, where you could really break down the concepts of how labor and birth could be different for recovery, and then also the baby and the process that the baby goes through on the postpartum side. So we went a little bit deeper with those topics because of our special population. So lessons learned. So we've done it once and we're excited that we'll be doing it again. So we are always wanting to evaluate and reflect back. So that's part of the process. If we're going to expect our trainees to do it with us, teach backs and really help us understand the concepts, we want to always be building and thinking, okay, how could we have done this better? And this group of trainees, they were always very honest. I loved that about them. They wanted more structure. They wanted a little bit more outline. So, we have improved that because again, boundaries for persons in recovery, boundaries and clarity is always better. So while the doula curriculum and the way we've presented it in the past, we've just been going with the flow, right? This group really wanted more. They wanted more anticipated topics. They wanted a guideline. They wanted to know what to expect. So we have improved that. We also know that the peer recovery specialist and the community doula, how those are the same and different, and how we're different, and how to emphasize the differences and the similarities. We do know if anyone has done a doula training, I don't know who's in the community today, but if you've ever done a doula training, you know that the training is wonderful. And then if you want to be certified, or if you want to observe your births and get all the things accomplished, that takes time. And what we know is that, not all the peer recovery specialists had connections in the birth world in their community. So providing ongoing mentorship and ongoing peer support, we continue to get together every month, helping everybody along with doing their observations and then creating the journals. And then through this, we did know that there is a high need for this to be statewide and to go into all communities. Because again, you've heard from Janessa, she is in the role now and she serves a certain part of South Carolina. So the idea is that now we know that it works and the need is there. And so what we want to do is make sure we're meeting other communities' needs.
This is me. So I'm just going to talk about what some of our dual certified trainees are doing now. We were really, really lucky to have an incredible group of high impact individuals. We have 2 of our graduates serving in an inpatient center, treatment center that specifically serves pregnant and postpartum, I think just pregnant women. They have a SAMHSA funded grant that incorporates Eat, Sleep, Console, and they've wrapped in the doula what they learned in the doula training. So they're leading groups that have prenatal support and postpartum support, as well as supporting individuals when they actually go to the births. And so this is a little bit easier because these women are in treatment. They are with them all the time. But we have 2 individuals who are working in that setting. We have Janessa, who is working in the outpatient setting. So the Women's Reproductive Behavioral Health Clinic at MUSC is a clinic that mainly delivers our services, which is reproductive psychiatry, so MDs, as well as therapy via telemedicine. And we do that because South Carolina, like I said, is a highly rural, a health shortage professional or health professional shortage area, really needs access, has access issues. So she serves as an outpatient that is integrated into that telemedicine-based virtual clinic. Her services can be both inpatient, could be both virtual or in person. She specifically serves one of the 4 perinatal regions in South Carolina. She is in one of the areas that has the highest rates of overdose and NAS. So she is positioned in a very good place to support these women. But she can also, like I said, support via telemedicine as we build up the workforce. We also had two individuals who go in and out of correctional facilities. The woman in this photo, Nikki, is she leads the peer support and MAP programs medication for opioid use disorder programs within correctional facilities through South Carolina. She works for the South Carolina Department of Corrections. So they are working really hard to get in and be able to support the pregnant populations that are incarcerated, which is incredible. And then we also had another individual who supports some of the work that's being done in correctional facilities, but she works at a large recovery community organization called the Courage Center in the middle of the state, and they are very involved with the credentialing and training, as well as family-based services for recovery. So we have some very influential trainees that we were super lucky to have. Next slide, please. Yes, okay. And then I will just end with some exciting news about the next steps. So we recently, at the beginning of the year, applied for a large SAMHSA grant in collaboration with our state substance use department. So they were the applicant agency, and they're going to pass through the work to us, so the South Carolina Department of Alcohol and Other Drug Abuse Services. And what this allows us to do, among a couple of things, are to increase this workforce. So we, over 3 years, are planning to train 24 individuals as community-based doulas and peer support specialists. So we're hoping to do about 2 cohorts a year. This also allows us some funding for MUSC specifically to hire additional doula peer support specialists that can serve in each of the perinatal regions. So similar to what Janessa is already doing, they'll have a doula peer support specialist in that region that can help support the continuity of care between inpatient and outpatient and connecting to services, as well as hopefully getting some of these individuals into our state 301s, our treatment centers, in collaboration with the Department of Alcohol and Other Drug Abuse Services. And one of our goals there is that we plan to provide at least 112 women access to these services, these wraparound services through pregnancy and the entire year postpartum, and as well as give them access to maternal mental health through telemedicine if necessary, for them and children who are affected by perinatal substance use by telemedicine as well. So, as I've mentioned multiple times, South Carolina is a state that is fully rural, fully medically underserved, fully mental health and health professional shortage. There's a lot of counties like that, a high proportion of women living below the poverty line or covered by Medicaid. So we're really going to be targeting going into these specific areas where access is super low to both prenatal and recovery services to offer this type of support, whether it's in person or virtual. So that's where we're headed.
All right, awesome. Thank you. We already have two questions that I wanted to pose to the group. The first is, I think, Molly, this may be mostly for you. What are the funding mechanisms that we use to support community doulas?
Okay, so we believe in paying salaries with benefits. So that's a different model than what some other communities are doing. Some communities have doula collectives where they get paid per birth. And we would like to get away from that model to sustain the workforce. But we also know that it's not realistic for all communities in South Carolina. So that is the optimal goal is to be able to pay salary with benefits to be in this role. South Carolina does not have reimbursement and compensation from any insurance provider, including Medicaid. There are 12 states that are ahead. We have started the process in South Carolina, and Birth Matters is helping support the steering committee, but it is a statewide steering committee that will be working. Policy work takes time, but we are working towards that, and we're hopeful that that can happen in the next couple of years. So the idea is that you're increasing workforce of community doulas. So when it is here, when reimbursement is available, we will have community doulas, hopefully in every county, willing to serve those on Medicaid. So I'm not sure if that helps explain exactly the pay models, but that's how Birth Matters and Spartanburg has always existed. We've always paid salaries, and 5 years ago we added benefits. And then I know MUSC is doing that with Janessa, so it's what we always suggest. And some communities, are doing that, and some are still doing the per birth rate through grants, donations.
Yeah, if I may, it's more than just a suggestion. For us, it's a best practice.
Yeah.
We knowing that we use a community-based workforce with that shared lived experience with the communities that they serve. These are more likely to be folks that are wounded warriors that are coming from low income and traumatized and disadvantaged backgrounds. And so we want them to have the stability of a consistent salary and full benefits. We don't want anybody coming from the community to have to work fee per fee, fee by fee, and hope that they get more clients. So it's really, really important. And I think that is something that you have taught us, Molly, and that we very much share that with other people, that these have to be salaried people.
Yes.
And do we have doulas that are full-time versus part-time?
So I also want to say, someone I think in the chat wants to know if the training is paid. So yes, we do pay stipends, we feed, we have a good time together. So that is
we pay for
also,
travel.
Yeah, and we paid mileage for travel.
It almost killed us, but we paid for travel. If anybody's ever had to reimburse through a university system before, you may feel my pain.
So that, yes, so we build that in before we even get started, because we know that those are important pieces. Important pieces, not just, if you work in nonprofit world, you owe your funders outcomes to say, we did this because of the money you gave us. So for us to be able to say 5 started and 5 completed, that's what you're wanting. You're wanting to prove that you were able to stimulate and keep them engaged. And sometimes that is incentive is valuable. Everybody deserves to be paid for this hard work. So yes, we do pay during the training. So part-time versus full-time, I will tell you that ideally full-time is of course the gold standard, because if you know anything about doula work, you're having to take call, you're having to really commit to the family around the birth time. Part-time, it's not that we don't have part-time doulas and that we won't start with part-time. Sometimes that's funding. Sometimes you have to start with what you have, and you say, we have this much. Will you do 10 families a year for this amount? And that would be a part-time position. So yeah, I mean, it's not that we're against it. It's just that sometimes it's not equitable because you can't really live off of it. So then you get a side hustle. And when you get a side hustle, sometimes your employer won't let you off for the birth. And so it just gets really hard and complicated. We do in Spartanburg have some contract doulas, meaning they've been through our full training and they get paid per birth. And it's because they love their job wherever they are. They don't want to leave their profession to do full-time doula work. But they have their employers willing to allow them to take 3 births a year, meaning they will take off. They will be able to take leave and be able to get off for the birth. So as long as everyone's clear, you can work with what people are willing to give back and support.
So we have another question from Marta.
Just
Oh, sorry, Courtney, go ahead.
Yeah, I'll just add, and I'll answer this last question that just came in actually, and add the process at MUSC, because we are a large medical academic research institution. It's much different than employing these individuals than like a nonprofit would. And we have been lucky that our program, the WRBH, has a history of large service grants. So we fund Janessa and the doulas that we're going to be bringing on through SAMHSA, HRSA, big grants like that. As far as receiving pushback about employing doulas, Janessa and actually everybody on this team can speak to, it took a very long time to get Janessa employed at MUSC, because when we went to go put her position in, they didn't understand what it was. Like, we kept each department that she could potentially fit into was very confused about like where she should be working and why. But eventually what was really beautiful is, as I described it to the OB/GYN department, to the psychiatry department, to all the different divisions that were involved, we ended up having just a list of people who had signed and said, this is something that we want at our institution. And they created a completely new structure for her. So her position is the first one at MUSC and at our medical university. There wasn't anything like that before, a pay structure like the salaried person with weird hours like that at MUSC. So, and that was because a lot of the OBs in those departments were like, this is something that we absolutely need. So we were lucky to have that.
Thank you for that, Courtney. We have so many questions rolling in. I'm trying to keep tabs on them. Quickly from Marta, how can we help people understand the difference between a doula and midwife better? So it sounds like she's had to deal with that too as a doula. Any thoughts on that, Molly?
If you just keep defining it, I think we'll keep, don't stay away from the word, because some people have moved from birth worker. Either word, just stay with it and use it and just keep defining it. And I also ask midwives to continue to define it too. I know there's some midwifery practices here in South Carolina, and they will tell their birthing persons, you need to get a doula. And so they're advocating for the birthing team to exist and it be inclusive of a doula. I will say that a lot of in South Carolina, we do have midwifery services, but we don't have a high number of midwives that practice using Medicaid. And because of a lot of our families that we're serving, they don't have the access to midwifery models like other birthing persons in South Carolina. So just stick with it.
Allison asked about assessing the outcomes of the families served by doulas. And I will say that not yet, because we just got trained. And as you all know, pregnancy is 9 months long. So we're still waiting even for Janessa's first families to have their babies. So, but maybe Molly, can you speak to some of the outcomes that you see in the general community doula family populations real quick?
Yes. So again, when you get started doing anything from a nonprofit, getting funders. So I know there's been a lot of questions around how we're paying. So we've had long-standing foundations that believe in our work, believe that prenatal before a child is born matters. And so when you have funders that get that, then they also understand the early years is really hard to do the direct service and capture a lot of evidence. And so Health Connect One did that for us in the beginning because we used their data system. And we still use a data system, but we have the ability now to extract the data out and provide the evidence. We have done several return on investments to prove cost savings. And we just recently, in partnership with the USC, we will be in partnership with the PCORI grant. I'm not sure if anyone on here knows that, but they are actually, we're going to be in with 6 different states that will be looking at doula outcomes specific to Medicaid families. So always, if you are in the doula role and you identify as a community doula, capture just 3 things. Capture your breastfeeding rates, your birth weights, and if the baby went to NICU, or if it was a vaginal or C-section. But choose 3 outcomes. Start somewhere and just capture it for everyone that you attend. And there's your evidence, because you can do a comparison of the state average. You might not be able to do your county average, but you can look it up and see what at least the state average. And that's where we start.
You can do your county average too. That C-section rate is money in the bank. So
yes, you
I agree
can.
totally. Yeah.
But doulas aren't data people. So, find someone that is into data. There are people getting their masters in all the universities that would love to support that. But just start with 3 and keep with them. Our breastfeeding rates are usually around 90 initiation, 90% of our families. So that's huge. Our babies are born healthier. Our babies less likely to go to NICU, born on time, all those things that funders like to see. And y'all, it's lifelong changes. It's not just, it's not just this critical time. We do keep moms alive, so we keep babies alive.
Yeah.
Doulas have been doing that, and it is changing. It is changing the communities to thrive. So stay with
And Sarah Covington Cobb will help you find those county comparison rates. So we're going to put our contact information back up here. And you don't have to go to the university. Look at me. I will help you. Kelly Roberts asked, and I would love to hear Courtney, you speak about this. These 5 trainees that we had in this first round were amazing. How did you find them and recruit them and select them?
Yeah. So I don't have like a really great protocol that I can give to everybody. I am somebody who has worked in and am very familiar with the peer support community in South Carolina. I'm a professional recovery coach. It doesn't really mean much. I don't have a lived experience of substance use disorder recovery, but I've worked with a lot of recovery community organizations. And have seen, what are the markers of success for people who do well in those organizations and people who, struggle a little bit in their practice. And I just interviewed everybody. I mean, people emailed me, we put it out. I had some of the recovery community put it out into Facebook groups and their networks, and people that were interested contacted me. I talked to them on the phone. I got a general sense of where they are, why they wanted to do this, what their motives were, what their lived experience was, and I kind of just vetted them myself. So I know that that's not incredible. I don't know if that's incredibly helpful. I could discuss with anybody if they're interested in some of the things that I looked for. Some of the very obvious ones are being strong in their recovery, just a compassionate outlook on life, their thoughts on different pathways, where they were with their own beliefs and values, like really getting into that kind of stuff. Because this work is no joke, right? It's doula work on its own is a difficult field. It takes a lot. And then you add that layer of recovery on top of it. I mean, these are people that need to be very, very solid in their own personal recovery and how they take care of themselves. So,
well, it may not be a protocol, but it's something that we see reflected in a lot of our work, which is, first of all, relationships.
Yes.
You need to have relationships with these people, and that's important. And the time that you have taken to know these people and build trust with those people is why we had such a great team. And then listening. I mean, you listened and you heard, we need doulas. We need somebody to be with these people when they're in labor to help them with, these care teams that may have been discriminating against them because of their medication for their opioid use disorder. So again, we hear it over and over again: relationships, trust, listening.
I do want to just add to that. It is all about the relationships. We did have an interest fair, which means we all came together and was really clear about the expectations, because not everybody has the flexibility and time. So, once Courtney had those conversations, we also had a very clear, Zoom about what this meant. I will tell you what not to do. is not to have a supervisor choose a staff member within a team and say, this person needs to be our community doula in our organization. If you're forcing someone to be a community doula, it will not end well. It is not for everyone. And just like we believe in choice and shared decision-making, the doulas need to be interviewed and they need to understand what they're looking at. And it needs to be, it needs to be a spark within themselves. And I forgot, we did start with 6. We did have 6 trainees and 5 graduated. So I did want to clarify that. That's very normal.
We have another question. The doulas are they paid by Birth Matters or the healthcare organizations in which they are working?
So Birth Matters, this is where the statewide concept is a stretch, but Janessa is paid through and is employed with MUSC. She was trained by Birth Matters. So that was something that Dr. King expected when they did their application for people of interest for their community doula hire process. Birth Matters in Spartanburg, it takes the lead on paying everyone in our direct service doula work that's in Spartanburg only. So we're all partnering together with strengths and funds.
So I think if this is getting at that kind of age-old question about doulas being employed by the hospitals in which their participants are delivering, not in the case of Birth Matters. In the case of MUSC, I guess tangentially, but the healthcare system is a little bit separate from the place where the women's reproductive behavioral health is. Is that correct, Courtney?
Yes, our division is in the College of Medicine, but we're the Department of Psychiatry division of the Women's Reproductive Behavioral Health. So we also are primarily a mental health division. We don't do any of the OB prenatal care other than mental health support.
So there is in these 2 cases, there is that separation between the hospital clinical care provider and the organization that pays the doulas. I know that's a sensitive subject in the doula world. Do our doulas pursue certification through a national organization, Molly?
No, Health Connect One provides certification for community doulas. So there is some talk that some people like to practice in the community doula space, and then they like to go with some of the larger doula certifying bodies. That's up to each person if they want to dive into that. It certainly is easier to go through some of the larger certifying bodies once you've practiced for a little while. So it's just up to the individual if they want to add that to their certifying trainings list.
Right.
I did see something about postpartum. So because we
Yes.
because we are in their lives, we suggest each community decides the saturation and dosage on the postpartum end, but Birth Matters says 6 months is the minimum and best practice is a year because you want to track infant mortality as well. Because those 2, keeping mom alive and keeping baby alive past 1 year increases lifelong survival rates. So,
and Molly, your curriculum is quite intense in the postpartum period. How often do your doulas see the moms in the postpartum period?
Yes, definitely.
And for the dual certified peer support specialists, we are going to go a full year postpartum because of some of those statistics that I mentioned in the beginning. A lot of women are falling off of their treatment at 6 months. There's also a really high spike in overdose rates at 9 months. So we really want to be there through that entire postpartum year to make sure that women or individuals are strong in their recovery in that first difficult year of parenting.
And what is it every week, every month? The
So the Health Connect One's replication requires 2 touches of the first 3 weeks of the infant's life, and then you go weekly. And then right around 6 months, you go twice a month. And so your dosage is a natural decrease. And we have seen that that is needed, because weaning out of someone's life that you've been a part of someone's life for so long, because we've been in each other's lives for over a year. It's important that you start weaning out and they start feeling empowered. Again, phone call away, a text away, but as far as encounters and home visits, we start weaning out. So it isn't so much, you start seeing the self-sufficiency with your own eyes. So then we go to twice a month, and then starting at 9 months to the 1 year, we see them once a month.
Yeah, and again, to add that the recovery layer onto that, a big piece of what our dual certified trainees will do is help, as Janessa described when she was talking, help them build recovery capital during that time. So as they wean off her, their support system in the recovery world is expanding.
Amazing.
Yes.
That's my first time here in recovery capital. I wrote it down. I love it.
I like that word too.
Yeah.
What I'm wanting to explain this model and this concept is doulas invest a lot of time into, and we pour into, but from day one, we're wanting to understand who's on their team, who is your support system. And sometimes people in early recovery, they ain't got many people. They just don't, they don't have a lot of people on their team.
I'd have no one.
So, right. And so sometimes the doula is really the only person. So you want to continually help them continually build persons in along the way, because it becomes a lot for the doula. It really does.
I'm sorry, I know we're out of time. I promised Heather I'd put the contact information back up, but also Heather, reach out to us anytime. You can find us in the conference information as well. Thank you, everybody. Thank you, Lynn and Amy from the Maternal Health Innovation team for, first of all, putting up with me, and second of all, helping out so much. And we really want to hear, and some of you have mentioned already in the chat that you have similar programs or are starting or are interested in similar programs. Please reach out. We want to talk. We want to hear. We are still learning, as you heard, and we would love to hear what you are learning. And what you're doing, and support each other in this process. So please do reach out and let us know. And thank you, everybody.